Hello, my name's Kim Eagle. I'm at the University of Michigan on the faculty in cardiology. We want to thank you for joining us today for this discussion about Heart Month. February is Heart Month, and we're here to talk about cardiovascular disease and how we might prevent it. I'm joined on the panel today by three very talented professionals in medicine from the University of Michigan, and I'm going to have each of them introduce themselves to you now.
Hello, I'm Veena Janardhan. I'm a fourth-year medical student at the University of Michigan, applying into internal medicine, and I'm very passionate about patient education.
Hi, my name is Richard Weinberg. I'm one of the preventive cardiologists at the University of Michigan, and I focus on the prevention of cardiovascular disease.
Hi, I'm Sue Reiskamp. I'm a cardiovascular nutritionist at Michigan Medicine. I support the outpatient program at the Cardiovascular Center and have the luxury of counseling patients one-on-one on not only cardiovascular disease but other risk factors.
So cardiovascular disease kills more women and more men than any other set of conditions across all the spectrum of disease. And it's actually been estimated that as many as 85% of these events, strokes, heart attacks, sudden death, could be prevented with effective attention to lifestyle and also, where appropriate, preventive medications. So today, over this hour, we're going to talk about the various risk factors that affect our chance of developing heart disease and some of the ways that you can attack those in your own life. So we're going to start with risk factors, and maybe I'll have you, Veena, give me a flavor of some of those that you think are important.
Yeah, so some of the main risk factors we consider with cardiovascular disease include smoking, which is one of the most avoidable kind of risk factors that we discuss, as well as diabetes, particularly type 2 diabetes, high blood pressure, and we look at different levels in terms of high blood pressure. So type 1 hypertension is classified as a number above 130 over 80, and type 2 is 140 over 90. Cholesterol, so there's two different types of cholesterol we like to talk about. One's HDL, which is usually referred to as the good cholesterol, and then LDL, which is usually referred to as the bad cholesterol. Right. And we typically like the HDL to be high and the LDL to be low. And another risk factor is obesity.
So one of the lessons here, of course, is you got to know your numbers. So you need to know what your blood pressure is. You should be seeing a physician from time to time to know what that is. You should know what your cholesterol number is and the various breakdown products of the cholesterol numbers that we get. The A1C is a measure of your glucose health over the last month or two. So these are some of the numbers that we all need to know in order to understand whether we might have risk related to those. Sue, what are some of the risk factors that we relate to diet?
So speaking of the biomarkers that you mentioned, we look at all of them in terms of coming up with a plan that can affect those numbers and bring them, shore them up with the, so every time I meet with a patient, we review all of their biomarkers, their blood pressure, the HDL and LDL. I also look at the hemoglobin A1C for blood sugar management, pre-diabetes, and then look at their diet in terms of what could be contributing to that. Typically, we see a highly refined carbohydrate, highly processed food diet can lead to and exacerbate those risk factors, as well as we mentioned the obesity too, that we found the higher the BMI is from normal, the higher the risk factors of developing not only cardiovascular disease, but other diseases, like we mentioned, the high blood pressure, as well as diabetes.
So if they have hypertension, you're focusing more on salt in their diet, perhaps. If they have diabetes, you're really attacking those refined sugars.
Yeah.
If they have a very high cholesterol, thinking more about perhaps fat in the diet.
Fat. Mm-hmm.
And many patients have a mix of those, so the diet has to be really carefully crafted to be optimized, doesn't it?
Exactly. Mm-hmm.
Richard, a lot of patients ask questions about how do the risk factors actually affect the heart? What's going on at the cardiac level that affects their risk?
So it's an interesting question. I think one that we're still beginning to understand the causes as to how risk factors themselves play into heart disease. Certain things we know that there's definitely a causal relationship. So for example, if you have high levels of bad cholesterol or other types of fat in the blood, those contribute to what's called coronary artery disease, a plaque, which is kind of like junk in the pipes that you would have in the pipes that bring water into your house. As that builds up, that can cause progressive narrowing of your coronary arteries, and then it can actually, in the long term, perhaps cause heart attack. And so we know there's definitely a causal relationship between elevated cholesterol and coronary artery disease. High blood pressure or hypertension is also related to coronary artery disease, but also very strongly related to the development of heart failure as well as stroke.
Right.
So people who have high blood pressure have significantly increased risk of all three, but in particular, high blood pressure and stroke.
Right.
Then you factor in smoking, which has long-term very bad effects on the circulatory system, on your lungs, makes the heart work harder. In addition, diabetes and obesity also play in, and they probably all work together. It's not just additive, but it's a synergistic, multiplicative effect that you can have with all of these risk factors in the person.
Right. I sort of remember one of my teachers saying that the risk factors don't add, they multiply. 1 + 1 + 1 = 8.
Right.
Because they tend to multiply. I once was given sort of a metaphor where diabetes sort of prepares the artery to be injured. Cholesterol is a nail, and hypertension is the hammer that's driving this into the plaque that ultimately can cause heart attacks, strokes, and sudden death. Vina, are these risk factors really modifiable?
I think most of them, yes. So it's particularly with smoking, and smoking can be very difficult for patients to stop, and so they require a lot of support in doing this. But avoiding smoking is definitely a big benefit for cardiovascular disease. Particularly diabetes, you can control a lot through your diet and medications as well. Regarding blood pressure, similarly, you can change it through medications and diet. With cholesterol, same thing, and obesity as well, as long as you also incorporate some exercise with it. So I think a lot of these are modifiable. I think one of them that is not modifiable is particularly sex. So male versus female risk factors can be very different.
Right, right. Smoking is a huge one, isn't it? It's said that chronic smokers lose on average 7 to 10 years of their life, on average, from smoking-related complications. Richard, what are some of the cues that you've used to help your patients stop?
All right, so I like to tell my patients that stopping smoking, or the first step, decreasing the amount that you smoke, is single-handedly the most important thing you can do for your health. And I try and emphasize a team-based approach. We all work as a team together to try and promote the health of our patients, and that the most important person on that team actually is the patient who is sitting in front of you. So the first thing is to speak with your patient and say, are you motivated to stop smoking? And we discuss that. Because you need to be motivated to quit, and then we try and set a quit date. And based on that, we can then develop a plan as to what the best way to help you stop smoking, because it's not easy. And the more you try, the more successful you can be, whether it involves counseling, removing yourself from certain situations that predispose you to smoking. So for example, if your friends smoke, perhaps not engaging with them in social situations where you're more apt to use a cigarette or tobacco. Stress in the workplace and in home could be a trigger for people, so we try and encourage them to have stress-reducing activities, meditation, for example. And then, of course, we have a lot of pharmacotherapies as well, which we use on a tailored patient-by-patient basis in order to increase the likelihood that they can stop smoking and remain tobacco-free.
Right, it's interesting that if we can get a patient to set a quit date, we have a chance. And then some of the patients need nicotine replacement. Nicotine is the addictive substance in tobacco, but it's really not the harmful substance. That's the smoke and the tar. So if we give them nicotine replacement gum or a patch or some other form, we can help them through. And then there are other medications that sometimes stop that craving as
Right.
well. Sue, when we start getting into how we attack the diet, specifically weight loss, et cetera, what are some of the tips that you really look for when you're counseling a patient and their family?
Well, the first thing I do is begin that conversation. Let's look at your diet. Let's be mindful about what food choices we're making. That whole readiness that you spoke of about quitting smoking also applies to any behavior change. So with the lifestyle, are you ready to make some changes? Are you motivated to make some changes? What might those changes look like? I do an in-depth review of their diet, either by what's referred to as a 24-hour recall or a typical day, to get a feel for what they're doing, what might be working for them and what might not be working for them. And like I said, have that discussion around what's working, what's not, what can we do differently, and go from there. Because typically we can find something that's not working in their favor, and we can just tease that out.
Do you see a lot of stress-related triggers to eating?
Oh, absolutely.
Okay.
Absolutely, for sure. Just like with the smoking, we have those triggers, so we can have that conversation about what is happening. And, chances are the patients are really interested in that support and help, and they're open to making those changes as well as sharing what they're doing. They're not lying, they're sharing so that they can get the support that they need. So I work more as a coach and helping them along the way to make those changes, and because it's little steps that's going to be the most helpful, and then encourage them to continue to make those changes, check those biomarkers that they're moving in the right way. And once they see that, it's even more encouraging.
I love that term, coach. I think that's what we are, and it also implies that this is not a one-time event, this moment with you. And I think the more you get into their plate every day,
No pun intended,
and start sort of substituting out things for more healthy things,
right?
that they can start to make progress in that regard, for sure.
I think that analogy is important because a lot of times patients say, I made a mistake, I'm not taking my medications, I fell off the wagon when it came to exercise or smoking, and reinforcing that this isn't about right and wrong, good and bad. We're here as an advocate for you. We're here as your coach. We're your partner in your health. You are the biggest and most important advocate for your health, but we're right here to help you. And you learn from failure, and you know that sometimes you're going to lapse, but the idea is to promote long-term lifestyle modifications to lead a healthier lifestyle over the course of your lifetime, beginning in childhood and teenage years all the way through young adulthood and later, in order to promote healthy cardiovascular lifestyle.
Right,
So-
right. I had a patient a few weeks ago say he was going to stop smoking on Super Bowl Sunday. And I said, why did you pick that particular day? And he said, because I've used it before. And I could have thought, well, that means he's failed before because he's smoking again. But the point is he's trying again.
Right.
And the longer he stays smoke-free, the better his health is going to be, whether it's for the rest of his life or for a year or even a few months. Now, Vina, you mentioned that the risk factors, men versus women. Tell us a little more about that.
So in terms of looking at different risk factors for men versus women, we look at particularly the age that maybe family members have had cardiovascular disease. So we classify premature cardiovascular disease in terms of age. So for men, we look at men in the family who've had a cardiovascular event before the age of 50, and then for women before the age of 60. And particularly this is because women tend to get cardiovascular disease later in their life compared to men. And then, we can also address within this various risk factors of smoking, diabetes, and hypertension. Each risk factor kind of affects men and women pretty differently.
Correct.
And some women have kind of increased risks with particularly like smoking compared to men.
Okay, good. Now, we're a fast food nation, aren't we, Sue?
Yes.
And somebody told me once that we develop our palate for salt, fat, and sugar when we're young, like between the ages of 3 and 5. And of course, lots of the target of fast food is in those three spaces: salt, fat, and sugar. How do people attack diet in this environment? What do you recommend?
Yeah, that's a challenge for sure. It's a behavior change. It's also thinking differently about foods as well. I link it to what I term intuitive eating, to think about what's good for me physically and mentally versus what's emotionally might feel good right now.
Right.
So, and going back to, if we look at more wholesome foods, what's good for me, what's going to make my body feel the best right now,
Right.
instead of, that fast food mentality, and maybe taking time out for ourselves to do some planning like we do everything else in our life.
Sure.
That's a lot of times I find that's on the back burner, and I try and bring that forward. It's worth taking some time for yourself, for that planning, even if it's like a half hour on the weekend to do a little bit of meal prep, or if it's just 15 minutes putting a list together. Or I have a lunch bag in my clinic and show them how easy it is just to pack. It doesn't have to be, sometimes we overthink things, but it could be just, grabbing a yogurt or a can of tuna fish or a piece of fresh fruit or some trail mix together that you can just have, so that you don't have, I forgot to eat, so I'm just going to eat fast food, because chances are you're going to do that and not feel good afterwards.
Okay. So we've talked in broad strokes about the risk factors and maybe a little bit in more detail about nutritionally the target. Let me ask Richard, what about exercise? What should be the target for a healthy lifestyle in terms of exercise?
Right, so exercise, lifestyle modification, activity is one of the most important parts about living a heart-healthy life. The American Heart Association recommends 150 minutes a week at minimum of moderate intensity exercise, light jogging, fast walking, dancing, for example, something of that sort. 30 minutes at a time would be great, so we would say 30 minutes, 5 days a week at minimum. To think about exercise activities you would need for weight loss, you would have to be north of that, probably close to 300 minutes of moderate to high intensity exercise. And what do we mean by moderate and high intensity? This gets asked a lot. Typically, we use your heart rate, so 220 minus your age is thought to be what your maximum predicted heart rate is. So 85% of that would be, which is a high intensity activity, 85% or higher. 65 to 85%, that's moderate. That's a good target heart rate for your activity. So when my patients say to me, what should I be targeting if I'm on an elliptical or another sort of exercise machine, I would say have that number and have that range. So you want to try and carve time out to do that.
Right. Make it part of
Make
your
it
life.
part of your daily routine if you can.
It's interesting. I find that some people are almost allergic to exercise. And so then I just talk about movement. I just want you to move, and I just walk on a treadmill for an hour a day for about 4 miles an hour. That's my movement. It's not intense exercise, but it's quite healthy. And we have to it's like the nutrition. We got to get into their life and say, well, do you have a treadmill? Do you have a bike? Do you have access to a Y or a gym close by? Is there a pool? If you're arthritic, what can we do to help you just move?
Right.
Right?
I
It's
tell
so healthy.
my patients to sit for 50, move for 5. So
Okay.
just to
Perfect.
look for ways to be more
Right.
physically active, less sedentary on a daily basis, or more on a
Yeah.
regular basis.
And there are ways you can build activity into your daily routine, even if you're not formally going to a gym or getting on a treadmill. So for example, if you take public transportation to work and the weather's nice outside, get off the bus stop 1 or 2 stops early and walk the rest of the way home. If you work in an office building that has a lot of square footage, take a walk in the building during the day if the weather isn't nice. Here in Michigan, it's sunny and warm all the time, obviously. So my patients say, what am I supposed to do if the weather's not nice? Well, you have large supermarkets or places like Costco or Walmart. You can go and walk inside if you don't belong to a gym. So there are other ways you can be active without actually getting up and going to the gym. So you can remove that sort of activation energy, so to speak.
And I like to measure my steps, try to get that 10,000. That's a lot. I mean, that's 5 miles a day. But one of the things about having step target is the steps you get in your workplace count. And then you can top it off with some walking or something later in the day. Vina, what are some of the misconceptions out there about heart disease that you've found?
I think one that I hear the most from patients is that heart disease is only controlled by the lifestyle choices you make. And for some patients, that's not the case. So in determining a patient's risk, we also like to ask about family history. And there are also some genetic disorders that patients may have that impact their LDL or bad cholesterol levels. So we always like to ask about family history. and as well as looking at very closely at their cholesterol levels to see if they might have one of those lipid or cholesterol disorders. And then we'll use that later to kind of classify their risk and help them find the best way to treat their heart disease.
Right. I think those are good points. What about you, Richard? Misconceptions that patients have?
Sure. So heart disease isn't just a disease of older patients, which is important to remember that if you do have a lot of risk factors, if you smoke, if you don't take care of yourself, if you're obese, even from a young age, unfortunately, we see people with heart attacks and strokes, oftentimes as young as their 30s. So it's not just a disease of older population. And as the rates of obesity and the rates of diabetes get higher in this country, we're starting to see people develop heart disease, stroke, heart failure, heart attack earlier on in life.
Right.
So very important to remember that risk factors can make heart disease occur earlier in one's lifetime.
How about you, Sue? Misconceptions that you've seen?
Well, on my end, a lot of times it's like it's inevitable, so there's nothing I can do about it. And so we have that discussion around, oh, you can modify this. It doesn't, even though the rest of your family may be obese or have heart disease, there are things that you can do to lessen the burden on yourself.
Yeah, I think that's an important one. Individuals who have a family history that really is nasty in terms of heart attacks or death at a young age, and this sense of inevitability and reversing that to say with lifestyle and medications, we can usually make a big impact on risk if we work together, particularly over a long period of time. Another one that I've seen quite a bit is individuals who are relatively healthy. They're eating a healthy diet, they're exercising, they're lean, and this sense of that they couldn't possibly have heart disease, and they need to know their numbers just like anybody else, because it's remarkable how ubiquitous this problem is in our society. I want to switch gears a little bit. There's a lot of sort of interesting diets out there, fasting, keto, etc. Atkins. Tell us your take about some of those things that are being popularized right now, Sue.
Okay. So, yeah, there are a lot of popular diets out there. You have to just remember that trendy diets don't always have the scientific base that some of are, like the American Heart Association recommendations around the Mediterranean diet. But that being said, when patients come to me and say, I want to try a keto diet or a keto-like diet, or I want to try intermittent fasting, I work with them to see if that might work for them. Because diets will work if you put the time and effort into it. We don't have a lot of data long-term, but short-term. But we keep track of those biomarkers. It's always first do no harm. But I have seen success with both working with patients with a keto-like diet as well as intermittent fasting. And to give you an example of each, with the keto-like, what's also happening at the same time where they're focusing more on higher fat diet, then they're eliminating those processed carbs. So, so the bad carbs kind of go away, and then we focus on the healthy carbs, the plant-based, the olives, the avocados, the nuts and seeds, nut butters, all good fats. With the intermittent fasting, we mentioned earlier about people stress eating or mindless eating or nighttime eating. When we put guidelines around when the opportunity to eat is versus not eat, that helps in terms of obesity, restricting calories, putting a limit on, instead of saying I'll just have one cookie after dinner and then the next thing you know the whole sleeve is gone. You say, well, after dinner, I'm done. That's it.
Right.
And there's some suggestion that eating according to your circadian rhythm is helpful too. Eat during the day, sleep at night.
Right. Okay. So the Mediterranean diet, we use that all the time. What does that really mean? I mean, I get this all the time in my practice.
Yeah.
I don't live in Mediterranean space. What does it mean?
So the Mediterranean, it's more of a meal plan that we found around countries that border the Mediterranean Sea. A lot of differences in those countries, but there were some common factors around being more plant-based, colorful fruits and vegetables, legumes, so more focused on plants, whole foods versus processed foods, high-quality proteins from unprocessed meats, so more lean red meats, poultry, lots of fish, versus our processed meats that are termed bacon, sausage, lunch meat, hot dogs that we tend to eat more of here in the United States. And healthy fats. I mentioned the avocados, the nuts and seeds. So that forms the basis of the Mediterranean diet, with the focus more on plants, but not animal restricted. Here at Michigan Medicine, we encourage a plate, half your plate vegetables, a quarter of your plate high quality protein, and a quarter of your plate a good fiber-rich starch.
Okay. So the keto diet, you don't necessarily have to have high-fat protein in it, do you?
No, we focus on plant-based protein from a cardiovascular standpoint.
Sure.
So, yeah, there's different levels of keto. A lot of people will say I'm on a ketogenic diet, but they're usually more on a keto-like.
Right. Richard, we hear a lot patients say, I don't know where to start with either my diet or my movement. What are some of the things you tell patients and families?
So I try and take a two-tiered approach. I sort of globally develop a plan that includes lifestyle modification, and specific to that, long-term goal is we would like you, if you're obese, to lose 20% of your weight. And that could be 40 or 50 pounds. And a patient looks at me and says, "Doc, you've got to be kidding."
That's a big amount.
But start with walking for 5 minutes a day and try and lose 5 pounds by the end of the month. Incremental, attainable goals, which can then reinforce a lifestyle modification, so that over the course of 3 to 6 months, a little plus a little plus a little adds up to a lot.
Right.
So I prefer to give my patients the long-term goal, which is achievable, but it's a tall peak. But each incremental step kind of gets you one piece closer.
Right. Dina?
I agree with you. I think setting goals for the patient is very important. So taking into account their lifestyle. So some patients have very hectic lives where they work long hours or they have young children. And we need to kind of tailor the goals toward each patient. And so with patients that may have barriers such as time, it may be helpful to kind of come up with a schedule for the patient day to day. And patients that have other kind of barriers, we can, such as chronic pain or fatigue, we can set goals of, like you said earlier, with swimming more than other kinds of exercise. And so I think setting small goals for the patient every time that we see them is very important.
So this really, I think, is useful because if a patient's fighting diabetes, hypertension, high cholesterol, extra weight, it's overwhelming. They're getting advice from all kinds of people. They're frustrated because they might have tried before and failed. And so identifying small victories that they can have in each of the risk factor lanes, once they have a little success, my sense is they start to feel like they have control. Do you know what I mean? I remember when I was taking care of Coach Schembeckler, he told me he couldn't exercise. He had very bad arthritis of his knees. He could not walk. And I said, well, we need to find you a non-exercise or an exercise program that doesn't involve weight bearing. And it happened to be the New Step machine that was developed here in Ann Arbor. And once he started doing that, he felt empowered. And he really then used exercise as a lever for mental health and also physical health and so on. So it's finding these little triggers that you can get started with and then moving beyond. So the Atkins diet, should we be plant-based totally? This comes up quite a bit.
I think more of a plant-based approach should be the foundation of our diet. Yeah, it's clear to me that a highly refined, high in terms of carbohydrates, that would be your refined breads, cereal, pastas, in addition to sugary beverages, treats like donuts and things like that. Obviously, you want to eat less of, but the focus also on good quality proteins, not just all protein, which is what the Atkins looks at. It doesn't look at the quality of proteins. It
Right.
includes high-fat meats that we don't think are all that good for you from a heart perspective. We still recommend a low-saturated fat diet, along with the trans fats, also a type of saturated fat, but again, more in the processed foods. But being mindful of the types of fats that you're eating, and if you don't have all those plants, you're missing out on a lot of nutrients. You know, there's a lot of many phytonutrients in the colorful fruits and vegetables that you'd really be missing out on and not, affecting the quality of your diet.
Right. Richard, when patients come with us, they have hypertension, they have high cholesterol. Because these are not things they feel, they're often reticent to take medications. And so naturally we try lifestyle first. And we've been talking now for quite a few minutes about attaining an ideal lifestyle is hard. At what point do you sort of then say, okay, now's the time for us to add medications to your efforts with lifestyle to reach a target?
Right. Great question. Difficult question to answer because, like you said, I think the job of a doctor is to make you feel better and live longer if possible. So if you are in middle age or younger part of your years, you're not thinking about one of those questions. And if you feel okay, then what pill am I going to give you that's going to make you feel better? And could there be side effects from the medications that I would recommend that could make you actually feel worse, which could lead to a lot of very angry telephone calls? The whole idea that I try and convey to the people who I help treat is, essentially, is the juice worth the squeeze? At what risk are you at for heart disease? Heart failure, stroke, heart attack? And what is the possible benefit of any sort of medication? And by medication, we could mean lifestyle change, diet, blood pressure medication, statins, or cholesterol-lowering medicines, right? What's the possible benefit from that intervention, and what's the side effect from that intervention? So for someone who, say, has high blood pressure because they eat a ton of salt in their diet but have no other risk factors, and their 10-year risk of a heart attack and stroke using one of our risk calculators is quite low, a trial of lifestyle modification is very reasonable. Now, that same person who's 20 years older, who also has high cholesterol, their 10-year risk of a heart attack and stroke will be significantly higher. So I would be a little bit more forceful in saying, I think the best thing for you would be your lifestyle changes, better diet, and also we should start a medication to lower your cholesterol, or we should start a medication to lower blood pressure.
Right.
And then I also then say, you need to remember that every medication can have side effects, but the benefits of these medications in the long term far outweigh the side effects in your particular case based on your risk.
So the calculation of risk, Veena, tell our viewing audience how a person could do that.
Yeah, so there's actually a website online where you can calculate what's called your ASCVD risk.
Okay.
And this calculator tells you both the lifetime risk as well as your personal risk. And I should kind of clarify that definition because it's not quite your personal risk, but let's say we took 100 people and we kind of compared everybody and we looked at people with particular risk factors such as those with high blood pressure.
Right.
Then of those people, there'd be a certain amount that we'd predict would get cardiovascular disease. So that's what that risk means.
So our viewers could go look up online ASCVD risk
tool.
calculator.
Yes.
And they could put in their numbers for
Yeah.
age, gender, blood pressure, cholesterol, and it would give them their 10-year risk
Yes.
and their lifetime risk.
Right.
And then Richard talked about the fact that if the 10-year risk is really high, maybe we move to medications earlier, and if it's really low, we give lifestyle a longer trial run. Is that what we're saying here?
Yes.
Richard, there's somebody asked me the other day about the calcium score, and that sometimes in kind of middle-aged folks, that might be a test that can help clarify risk. Could you tell the audience about that?
Sure. When it comes down to it, a very simple person. I'm almost binary, or in this case, I would partition people into 3 groups. Very high risk are people who unfortunately already have heart disease. If you've had a stroke, if you've had a heart attack, that changes the game entirely. In which case, a calcium score, which is a CT scan of your heart, and you actually measure the calcium in your coronary arteries, okay? that isn't going to help you in terms of deciding what your blood pressure target should be, in terms of whether or not you should be on cholesterol-lowering medication. Okay? Then you've got the very, very low-risk patients who come in, who are already healthy, who have no risk factors. Very, very rarely would a calcium score there help. So what you're left with is this gray zone. So you have intermediate risk people.
What does that mean?
So that means, depending on what criteria you use, we would define intermediate risk as a person who has an estimated 10-year risk of heart attack and stroke of between 5% and 7.5% per year, per every 10 years, based on the calculator that we discussed. Now, in those patients, you can have a discussion with them, and some people would say, hey, I want to start a medication now because I don't mind taking a pill. And then you'll have other people say, I don't want to take a medication if I don't have to. So in that case, if you were to get an additional screening test, something like a calcium score, if you see the presence of calcium in the arteries that supply blood to the heart, that can indicate that you have subclinical coronary artery disease, and it's a marker of long-term risk. And as a result, it may reclassify that intermediate risk patient into a high-risk patient or a higher-risk patient, at which point the juice would be worth the squeeze to take a statin. Yeah. On the other hand, if you have someone who truly is an intermediate risk patient who then has a calcium score of 0, then you could reclassify that person into a lower risk group, at which point intensive lifestyle diet therapy, and then you can reevaluate them at a subsequent visit. But you could steer away from taking a statin, for example.
So that's the calcium score is what? It's a super fast CAT scan, and it just shows if there's any calcification in the arteries to the heart muscle?
That's right. So what it does is that it's a CT scan. The entire test, the picture taking, is actually less than a minute. Getting prepared for the test takes much longer, but it just gets a picture of your heart, and then using a special computer program, you look for calcium in the heart, and you can actually quantify how much calcium there is. And based on a lot of population studies that have been done, we know what the percentiles are based on your age, your sex, and your race. So we know what the average number for the 0, 25th, 75th, 99th, 90th percentile is for people.
Terrific. So there's what the MESA risk calculator. If you've had a calcium score, you could go online and look up MESA, M-E-S-A, risk calculator, and that would be a modified risk estimate based on having the calcium information.
Yeah. And the nice thing about that calculator is you can input your data with and without the calcium score, and it will tell you what the change in risk is as a function of your calcium score.
Right, okay. Sue, sometimes people ask us if they have physical barriers to exercise, Michigan winters, for example. What should we recommend for movement for them?
That's a really good question, because here in Michigan we get that all the time, little elderly young people too. What I encourage them to do is use the internet today. As long as you have the internet, you can go on that and you can do all kinds of activities from, I will just show them in my clinic, why don't we just look up 5-minute chair exercise? And we'll do the exercise together to show them how easy it is to do. And put in the search bar whatever you want to try and do. I have a lot of people who are exercise challenge, who are have to be in a walker or whatever, but they can do exercises in a chair. We can exercise to Justin Timberlake if we want to. The only trouble is when you're in the car and you hear that song come on, you sometimes have to remember to still hold on to the wheel. But I like to show them activities that they can do that's fun and not having to be weight bearing when they can't.
Yes. So they, in their own life, with their own situation, they can do all kinds of things.
Absolutely.
Richard mentioned, I think, something with, get up every hour. I have a tracker it's actually a sensor that if I've been sitting for 50 minutes, it sends a message to my iPhone that I'm supposed to get up and move around a little bit. And even in some of the classrooms now, we're doing experiments where we have the kids in classroom spend 5 minutes standing and moving around in each hour of class to try, because they lost recess in the schoolrooms in large measure, but any movement is really very healthy. So I'm going to get personal now. I'm going to ask you, what's one thing that you've done in your life that's improved your cardiovascular lifestyle? Let me start with Vina.
Sure. So one thing I've done kind of within the last year, as a student, I don't have a lot of time to kind of fit in a normal exercise routine. But what I do is try to find some exercise classes that might be at the local gym, or if one of your barriers is kind of money, you could find some free videos online, and usually they're about 50 to 60 minutes, and I try to do at least one of them per day, and that way it also motivates me because I have other people doing them with me.
That's awesome. Richard?
Time constraints a problem.
Yes.
So people put aside time to work, sleep. I put aside also time to exercise. So there's a block of time that I'll have that I say, on the weekends I'm going to take an hour on Saturday, an hour on Sunday to exercise. I'm going to exercise for an hour during the week, so I make sure I can get my 180 minutes or my 150 minutes in. Because if you are strapped for time like I am, that's one of my major barriers. I have to block off time that's protected for my health so I can exercise.
Okay. Sue?
I found I needed to do a better job at stress management, and I learned from my patients too, sharing those experiences. So I started mindful meditation as a form of exercise, mental exercise, and I found the wonderful benefits of that, and I'm able to share that with my patients as well.
Okay, terrific. For me, it really was the step counter. You know, using the Oura Ring or my iPhone and counting my steps and basically saying, I'm trying to go to bed with 10,000 steps every day, kind of gave me the internal competition, I suppose, to reach that target, and was somewhat transformational, I would say, in terms of how I feel physically. The other thing interesting about exercise is it feels good when you're done, because it raises endorphins, and so it's a mood elevator too, which it can be useful when you've had a long day studying, right, Vina?
Yeah, definitely.
For sure. So, you know, Richard, what should we be telling the audience in terms of how often should they see a doctor? How often should they know and check their numbers? Where are we at with that as a society?
Overall, I think that's a problem that we have. We don't see doctors in the United States as much as, say, other comparable countries. At the very minimum, primary care doctor, if you don't have a whole lot of medical problems, at least once a year. You should have your blood pressure checked at least once a year. If it's abnormal, you should probably have it rechecked within close succession, or have it checked either if you buy yourself a cuff or you check it at home. Cholesterol. So everyone in young adulthood should have a cholesterol panel to screen for how high your cholesterol is, because there is 1 in 250 adults can have something called familial hypercholesterolemia, or heterozygous familial hypercholesterolemia, which is just medical jargon for saying you have very high cholesterol. And it's pretty common, and it's underdiagnosed. And so in infancy, in young age, up at the age of 2, typically you'll get screened, and then in your 20s you'll get screened. And if you're elevated, then you probably should see a doctor a little bit more frequently than once a year. We find that oftentimes young adults, when they get into college, graduate school, feel healthy, oftentimes don't see physicians that frequently. Medical students are actually very bad about it. I can speak to that. But it's important to maintain, you know, routine preventative care, and that includes your flu shot and making sure that your blood pressure is okay, and screening for cholesterol disorders.
And so, and then who should see a dietitian?
Well,
Everybody?
I'm biased. I think everyone should see a dietitian, because it just pays to get a check on what my diet is doing for me. Obviously, I can't see everyone, but I think once you tease out some of these risk factors, if we want to focus on making these lifestyle changes, then that's the time to see the dietitian sooner rather than later. And then based on their availability, I do routine follow-ups with them. Because of our patient population, as we all can appreciate, they come from all over the state. I typically link an appointment with the dietitian with the physician, so that it's a combined appointment.
More convenient.
Right.
Yeah, I think it's hard in a routine office check for a physician or a nurse practitioner or PA to get into the depth that's really needed to understand that person's issues with diet and where we might begin to tweak and make progress. So Richard really pointed out we need to know our numbers. So if you don't know what your hemoglobin A1C is, what your blood pressure is, what your blood cholesterol and the various parts of that are, you should know those. Those are important in terms of helping assess future risk. An issue that comes up sometimes is there too much exercise? Does marathon running, is that healthy? Richard, what do you think?
Interesting question. Moderate activity, I think, is we know is cardioprotective.
Yeah.
Think about it. We know that that's cardioprotective.
Right.
Endurance, high level, Olympic, professional level of endurance activity, the heart definitely changes under those
Right.
conditions. And sometimes people can be predisposed to abnormal heart rhythms or heart disease in the future. We don't necessarily know if it's causal or not. Abnormal heart rhythms being the big one that we know that
Yeah.
in a group of people who are ultra marathon runners, for example, there's a higher rate of atrial fibrillation in those patients. So I think that we separate the difference, that if you exercise 5 times a week, an hour each day, and it's moderate intensity exercise, chances are that's going to be cardioprotective.
Right.
The ultra-marathon runner or a competitive athlete, I think that there definitely is structural changes in the heart which adapts. And the long-term consequences of that, I think we're still not 100% sure about. What do you think? Because I know we've got a big athletic program. We see a lot of athletes, and
So people who exercise that much, a lot of times it's a lifestyle that they absolutely adore. They just get such both physical and mental health from that much exercise that it's hard to pull them back. I tend to say, like you do, that moderate exercise is terrific. Whether they get added benefit from going 3 hours instead of an hour, I don't know. Some of them seem to calcify their coronaries maybe a little more aggressively, but I'm not sure that that's necessarily bad. Exercise is great. I don't know if it's true that there can be too much, but it's an interesting debate. One of our listeners was interested in SCAD. This is this rare type of heart attack, predominantly in women, where one of the arteries dissects or tears. Tell us what we know about that, Richard.
spontaneous. So SCAD stands for spontaneous coronary artery dissection. That's when, if you think about the analogy of one of the coronary arteries, which is an artery that supplies blood to the heart, calling it a tube is a bit of a gross oversimplification in that it's actually a muscular tube that has 3 major layers, each one having different properties that affects blood flow to the heart. You can have a tear in these layers, which can cause a heart attack. And at first it was thought to be more of a rare occurrence, but as we become more cognizant, we realize it can be more common than we think and can be associated with other types of diseases, one in particular called fibromuscular dysplasia. So if there's a young person who has a heart attack due to spontaneous coronary artery dissection, we treat them typically with medications. At the same time, we also recommend that they see a specialist who deals with vascular disease, particularly evaluation for fibromuscular dysplasia. And that has to do with taking pictures either by MRI or more commonly with CT of all the blood vessels actually from your head all the way down to your legs to see whether or not there's any findings for fibromuscular dysplasia. If anyone's interested in that, we have a very we're part of a fibromuscular dysplasia registry here at the University of Michigan, and we have people who specialize in this type of disease.
Something we haven't talked about is alcohol. Is alcohol part of a healthy lifestyle or not? Let me start with you, Sue.
Personally, I think alcohol is overrated. I hear people say, well, the American Heart Association says if I'm a man, I can have 2 drinks a day, and if I'm a woman, I can have 1 drink a day. But the reality is that, a drink is a drink, like 4 ounces of wine, 1 can of beer, 1 shot of a liqueur. And, to suggest that people do that for heart health, I think is a misnomer. I encourage people, if they don't drink, not to start drinking, and they don't need another addiction. So,
Well, we see so many consequences of overuse, I
Right.
suppose. The studies, I guess, do suggest if you drink a very small amount, and it's really small, it's not
Right.
10 ounces or 20 ounces, but small, that it's hard to show that that's harmful in terms of cardiovascular disease. Whether it's helpful, I think, is perhaps debatable. What do you think, Richard?
I agree entirely. I enjoy wine personally, but everything in moderation is extraordinarily important. I never would counsel a patient to start to drink for cardiovascular or other sort of health benefit, to make that 100% clear. The American Heart Association, if you go to their website, and it's available online, will say similar, not to drink alcohol for cardiovascular benefit. The recommended alcohol consumption for men and women is 1 standard drink per sitting for a woman, 2 standard drinks for men at maximum. And that is neutral in terms of, we don't think that there is benefit, or there's no real proven benefit, but then there's no proven harm. Every patient is different. Every patient reacts to alcohol, which is a depressant. It can also dehydrate you differently. Overuse, like you said, has a lot of bad consequences for health. Liver disease, heart disease, behavioral and addictive disease. So everything in moderation. But again, if you are not an alcohol drinker and you are thinking of drinking alcohol for cardiovascular benefit, I would counsel you not to do so.
And is this consistent with the teaching at our medical school today, Vina?
Yes, we are taught about the guidelines of men no more than 2 drinks per day and women no more than 1 drink per day. But I think we would all agree and be taught on the fact that we don't encourage alcohol intake in terms of heart health.
Right. There's another area that's, I think, really interesting. And, you know, part of a person's shape is genetic, and part of it is environmental. And our patients have a really challenging time reversing obesity. Even if they achieve a healthier lifestyle, that can be challenging for them. You know, ironically, if you look at, if you control their blood sugar and their blood pressure and their cholesterol, and if they're active, eating well, then being overweight almost vanishes as a risk factor. And that can be good news to people, because they've reached a shape after 50 or 60 years or 30 years, and reversing that is hugely challenging. So if they'll work with their care team to manage the risk factors that can be associated with being overweight, they really dial down their risk, even though they may have not made a huge change in their weight or their shape. Is this something that you talk about, Sue, when you work with people?
Absolutely. We always have a conversation around their weight and what their goals are.
Right.
And I might have a different conversation if their BMI is less than 30 versus...
What's BMI mean? What's that?
So body mass index
Oh,
is your
okay.
weight relative to your height.
Right.
So it's just a measurement, a marker that we use in terms of what's normal weight relative to your size. So
Right.
the taller you are, the more weight you can have. So a normal BMI weight is like 18.5, I think, to 24.9. And then overweight is that 25 to 30. And then above that is considered obese. And what we find in studies, that the higher the BMI is from 30, the greater the risk. So I'm actually comfortable with people saying, if their BMI is around 30, I'm okay with this. Let's just focus on lifestyle factors, as long as we can tweak the diet to get the results that they want. But we do know, like if I have a patient that has a BMI of 40 or 50, which unfortunately we do see,
Right.
even though it's more challenging, the focus would be on, let's see if we can get that weight down, see if we can get that BMI a little bit closer to
Right.
30.
There's lots of, there's this history of vitamins and heart disease. It seems like we've gone through them all. Tell us about that, Vina.
Could you state
So
the
are there
question again,
vitamins
just
that we should be
vitamins?
taking to promote heart health?
So as far as I know and I'm taught, there's not particular vitamins we would encourage. We sometimes tell patients to get on a multivitamin daily if that's their choice.
Right.
But there's no proven benefits that I know of taking certain vitamins for heart health.
They've all been sort of studied. Vitamin C was used, and then it kind of fell by the wayside. Vitamin E didn't seem to work in a Western society. Vitamin D, for bone health, I suppose. Is that how you teach, Sue? That
It is. You know, I, being such a foodie myself, I lean more towards the foods rather than vitamin supplementation. Obviously, if there is a reason, a deficiency, then that would be a reason to supplement. But I think what we're learning is that it's more the combination of the nutrients and the vitamins in the food where we get the benefit versus a single pulling out a vitamin and saying this is going to be the magic bullet for you.
right.
So that's
And
the
there's
approach I take.
There's all kinds of other things like additives that have sort of come and gone, whether it's ginger or garlic or you name it, a hawthorn root. They've all been studied and don't appear to be in isolation of particular benefit, but they might live in vegetables or fruits that generally
Exactly.
are healthy. Is that right? Richard, one of our viewers is really interested in the comment that you made about familial hyperlipidemia and how we test for that and how a person would be genetically counseled for that. Can you tell us more?
Right, so there are a lot of different inherited cardiac conditions. The one that you're referring to is particularly for high bad cholesterol. You have 2 copies of every gene, and there are 4 genes that are implicated in this disease. And if you have 1 bad copy, it's called heterozygous familial hypercholesterolemia. If you have 2 bad copies, or 2 different copies that are both not functioning correctly, it's called homozygous. Homozygous is very, very rare. That's typically picked up in youth. The heterozygous is much more common, between 1 in 250. Is kind of is in the general population now. Okay. If your cholesterol is really high on a routine cholesterol panel and it's repeated and it's still high, typically you'd come and see a cardiologist or a lipid specialist, and a blood test could help figure out if that's the case. Speaking more broadly to genetic testing for other cardiovascular diseases, there's a lot on the horizon in terms of polygenic risk scores using a bunch of different changes in genes, although that hasn't really hit prime time yet for risk prediction. But as you know more probably than anyone, there are genes associated with aortic dissection, spontaneous coronary artery dissection, hypertrophic cardiomyopathy, other types of cardiomyopathies, which are diseases that make the heart muscle too weak or too strong, for example. And that's on a patient-by-patient basis in consultation with a specialist.
So the promise of genetic-based treatments and so forth is still maybe a ways away for most of our common conditions, but for some of our more rare conditions, it's here and it's available right now. And this would be an example where if you have familial hyperlipidemia and you genetically test positive, then you would definitely want first-degree relatives screened for it and your children screened for it, because you could have a 15-year-old who has a cholesterol of 300, where we would be thinking about getting that down right away.
Right, and we have very good data to suggest that even young people, as young as the age of 6, if you're treated for this condition, it actually prevents heart attack in the future, which is very encouraging because we have very effective medications which are safe, which you can take from a very young age.
We're beginning to get close to the end of our time together. Let me ask each of you for maybe a final word that you would like to give our viewing audience today. Sue?
So I guess the message I'd like to give people is that take care of yourself, be kind to your body, ask yourself what you can do to live as healthy and as long as you want, and you can do it if you want to.
Great. Richard?
I would say that you're the most important member of your healthcare and heart care team. So you should be your advocate for your own health, and the important thing is for you to find a care team, whether it's a physician, a registered dietitian, a physician's assistant, nurse practitioner that can work with you in order to maintain a heart-healthy lifestyle throughout the course of your lifetime.
Great. Dina?
I would say be patient with yourself. It takes a lot of time to kind of reach these goals. And setting those small goals for yourself, like we talked about before, can really help to encourage and motivate you to reach those bigger goals.
Love that. I guess I would say that you need to know the numbers that matter in terms of your risk, and that it's a journey. It's not a one-time, see a physician, I either make the changes or I don't. It's all about relationships. And one of the things I like about our panel is that we come from different age backgrounds and orientations, but we're all part of a team that's working with people like you to try to identify your risk and work with you to make changes. You are the target of the coaching. You're the player in this game. And if we work together to attack problems that could affect you later in life, we can do a lot to influence lifespan and also the quality of life that people have. I want to thank all of you for joining us today. It's been vigorous and enjoyable for me. And thank our viewing audience today for spending time with us at Michigan Medicine to talk about heart health. And in February, celebrating Heart Month, it's a time for us to reflect on where we're at and hopefully take action to live happier, healthier lives. Thank you.